Welcome all. My name is Susie Vasilevska and I've been a patient of your next speaker for over 30 years. I would like to introduce to you all Associate Professor Monica Rossleigh. Dr. Rossleigh will be talking to you about radioactive iodine use in the management of patients with thyroid cancer. Dr. Rossleigh has 41 years of experience in the management of thyroid cancer. Her initial training in thyroid cancer management occurred in centres in Sydney and Perth, Australia. Subsequent training occurred at the Memorial Sloan Kettering Cancer Centre in New York under the supervision of Drs. Benua and Leeper, who were internationally recognised thyroid cancer experts. On a consultant level, Dr. Rossleigh has run 2 thyroid clinics weekly since 1988. Initially under the directorship of Associate Professor Murray, who was a thyroid endocrinologist and nuclear medicine physician. On his retirement in June 1994, she became department head and took over his thyroid practice and has been managing thyroid cancer patients ever since. In 2007, the Prince of Wales Hospital Thyroid Multidisciplinary Meetings commenced, and Dr. Rossleigh has been chairing these meetings since. In 2014 and then 2015, she was the scientific program director of a thyroid masterclass run by the Australasian Society of Nuclear Medicine Specialists. In June 2020, she was invited to join the executive board of Thyroid International Recommendations Online. Prior to COVID, Dr. Rossleigh was a regular attender of international thyroid meetings run by the American Thyroid Association, European Thyroid Association, and World Congress on Thyroid Cancer. She is very much looking forward to attending these again in person post-COVID. Dr. Monica Rossleigh will now begin her talk.
Thank you, Susie, for that introduction, and thank you, Gary, for inviting me to give this talk. I'm just starting this talk with a picture of Sydney for the Americans who may not have been here. Our 2 best known features are the Harbour Bridge and the Opera House, and this picture was taken on Australia Day, where we have a regular ferry race. You can see these ferries in the beginning. These ferries plough the harbour, taking people from one side to the other, and on Australia Day they have a race.
Dr. Rossleigh, you already have one question
that
popped up if you want to answer it.
Sure.
It's from Sloan. Hello, I had my first and only treatment of RAI on the 9th of 11th, 2015. I have EOE, eosinophilic esophagus, and thus have a mobility disorder and frequent episodes of food and meditation impaction. In knowing this, my nuclear medicine physician instructed me to chew the 1-131 as to prevent it from being lodged in my esophagus. Since having RAI, my GI and EOE issues have increased immensely. My gastroenterologist said that chewing 1-131 most likely destroyed my digestive system. Could this be the case?
I haven't experienced a patient with your condition that I've treated, but I wouldn't have thought so, because we classically give it and it gets absorbed across the stomach, but I don't know if I can really comment on your individual case. I'd really have to defer to the physicians looking after you. So I think I'll go ahead with my talk now, which is on radioactive iodine use in the management of patients with thyroid cancer. I don't have any financial disclosures to report. I've got radioactive iodine has a half-life of 8.1 days, and it emits both beta rays, which are the rays that treat the cancer, and they deposit energy locally to destroy cells by radiation, And it also emits gamma rays, which travel a long distance in space, and that enables us to image where the radioactive iodine has gone to show the distribution of the disease after the treatment. So the first treatment of radioactive iodine, which delivers targeted internal radiotherapy, was administered in 1941 at Massachusetts General Hospital in Boston by Dr. Sol Hertz, who initially used it for the treatment of hyperthyroidism and later for the treatment of thyroid cancer patients. And it was really the beginning of theranostics, where you can do a scan with a radioisotope, and if the disease takes up that isotope, then you can treat that cancer. So now we have other conditions that we can treat, similar to I-131 for thyroid cancer. So in kids with neuroblastoma, we can do a scan of MIBG, which is taken up by those cancers, and we label it with an iodine. And if there is uptake, we can then attach radioactive iodine, the same form that is used for treating thyroid cancer, to treat the neuroblastoma. There's also gallium dotatate, which is a PET tracer used in PET scanning. And if the tumours are hot on the scan, then we can add lutate, which delivers beta radiation like I-131 and zaps the neuroendocrine tumours. And more recently, we can use this technique in men with prostate cancer. So we can do a scan, a PET scan, using PSMA, and if that PET scan is positive, then we can add the lutate, which emits beta rays like radioiodine to treat the prostate cancer metastases. Is that another question, Susie, or?
No,
no more. Okay, okay. Now, radioactive iodine can only be administered to thyroid cancer patients who've undergone total thyroidectomy, and that's the way we treat. Now, I understand that in Boston, they're giving radioactive iodine to ablate people who've only had one lobe out. My understanding is that that doesn't adequately ablate the residual thyroid tissue. So I think it's preferable, if you're going to give radioactive iodine to treat the cancer, to get rid of all the normal thyroid cells first, and then give the radioactive iodine, because it only treats small volume disease. It can't treat big bulk disease. So if you've got bulky disease, it's better if that disease can be resected first and then give the radioactive iodine afterwards. We do baseline testing, full blood count, just to make sure the marrow is okay, and kidney function. If people have got poor kidney function, the radioactive iodine is slower to get discharged from the body, and that can have an adverse effect on the bone marrow. So we may have to reduce the dose administered. We also need to make sure that women aren't pregnant at the time of radioactive iodine, and it is recommended that pregnancy should be avoided for at least 6 months after radioactive iodine. We also should make sure that breastfeeding has ceased at least 3 months prior to the radioactive iodine, because the iodine goes to breast tissue and you don't want to irradiate the breast tissue, which is very radiation sensitive. And we do a diagnostic I-123 scan, a different form of radioactive iodine, to make sure that there's no breast uptake before we administer the radioactive iodine treatment. Now, I did have a patient, I've had quite a few patients who developed thyroid cancer during pregnancy, and they often will breastfeed afterwards. And I won't treat them less than 3 months before they've ceased breastfeeding. And I always do this diagnostic scan. And I had one patient in the last few years who we had planned to give her the treatment, but there was still breast uptake on that scan. So I said, we're going to have to defer that treatment. We deferred it for another month, and on that follow-up scan, there was no uptake and I could treat her. And on the post-treatment scan, there was no breast uptake. Now, she did develop breast cancer about 2 years later. And I'm very glad that I delayed the radioactive iodine, because I would have been blamed for inducing that breast cancer, whereas I have evidence that there was no uptake of the radioactive iodine in her breast tissue. And she was just unfortunate that she's had 2 cancers in close succession. The other problem is if patients have iodine contrast for CAT scanning before the radioactive iodine treatment. Now, the most important thing is the surgeon should be comfortable with what operation is needed. And if a diagnostic CAT scan is needed before the operation, that should go ahead. But we need to wait at least 6 weeks, because we don't want the iodine contrast from the CAT scan to interfere with our radioactive iodine treatment. There are cardiac medications. Amiodarone is a drug used to treat cardiac irregularities of the heartbeat. And the problem with amiodarone is that the iodine in it is stored in the adipose tissue for a very long time, 10 months or even longer. After you stop the drug, you'll still have iodine in fat. So in these patients, you definitely need a pre-treatment scan to make sure that radioactive iodine is feasible. If there's no uptake anywhere on the scan, it means the iodine from the amiodarone is still hanging around, and we have to delay the treatment.
Dr. Rossleigh, there is another question.
Sure.
From Carol. I was advised I had a low-risk papillary cancer in 2016, followed with full thyroidectomy, and then 1-131 same year, also received 1-131 in 2017, and again in 2019. I am concerned, since I'm told now at the 5-year mark, my ultrasounds will be every 5 years. I'm not aware of other low-risk patients that have had 1-131 3 times within 5 years. Is this a previous normal practice by doctors?
Look, I don't know the exact details of your case. I don't know why you required 3 treatments. So I think you'd really have to defer to the doctors looking after you, because I don't know the details of your case. But I do know that neck ultrasound and thyroglobulin measurement is a mainstay in following up thyroid cancer patients looking for any evidence of disease recurrence. So I think you'd need to talk to your doctor about more detail as to why you needed the 3 treatments. That's all I can suggest. Okay, in preparation for radioactive iodine, we place patients on a low iodine diet because we want to wash out all the iodine from the body. And because that iodine is a competition for radioactive iodine. And I always tell my patients, this is a disease that, this is a diet that you need to go on, but your family shouldn't go on, because iodine is actually very good for you. It's good for the health of everyone, but for a short period, you need to have that restricted prior to the radioactive iodine. We don't routinely measure the amount of urine excretion of iodine prior to the treatment, but we do need to have the TSH, that's a hormone from the pituitary gland, adequately elevated so that the radioactive iodine can go into the cells. You need a TSH above 30 for the radioactive iodine to go into the cells. Now, when I first started treating thyroid cancer patients, all patients needed to come off thyroxine for at least 3 to 4 weeks. In some patients, we could give them short-acting thyroid hormone, but for at least 2 weeks before the radioactive iodine, there should be no short-acting thyroid hormone, and thyroxine should be withdrawn for at least 4 to 6 weeks. And we need to measure and make sure the TSH is above 30. Now, several years ago, recombinant TSH thyrogen became available, and it's really revolutionized the way we can treat thyroid cancer, because we don't have to make people go underactive thyroid. They don't have to be tired, no energy in preparation for the treatment. This is just 2 injections that are given intramuscularly day 1 and day 2, and on the 3rd day we give the treatment. In people with high-risk disease with probable metastases, thyroid hormone withdrawal is still preferred. But some centres are still using Thyrogen in that setting as well. So if Thyrogen or recombinant TSH is used in patients with metastatic disease, the dose to the metastatic foci may be lower than after thyroid hormone withdrawal, and so you need to give an equivalent or perhaps even a higher administered activity of radioactive iodine if you're going to use recombinant TSH in that situation. Now, in patients where the cancer is in the brain or spinal cord or in the main vessels coming off the heart, that should really be addressed first. And if there's residual disease there, then steroids should be given to reduce any swelling and risk of damage to those organs with the radioactive iodine, which can swell and cause compression of these organs.
Dr. Rossleigh, we have two more questions that have come in. The first one is, why is hormone withdrawal preferred for high-risk patients? That's the first one.
I'll just answer that one because, as I just said on this previous slide, that the dose to the metastatic foci may be lower. So you may be not treating the metastases as well. But I do know that several centres are using recombinant TSH, but then they are likely to need to give a higher dose of radioactive iodine in that setting. I think withdrawal results in a higher dose to the metastases.
And the next one is from Amelia. Can radioactive iodine be used to treat, I think, MTC?
Medullary thyroid cancer. MTC?
Yeah, MTC.
Yeah, no. Medullary thyroid cancer is from the calcitonin secreting cells in the thyroid, and those cells don't take up radioactive iodine. So it's only used in papillary and follicular, and variants of papillary and follicular, but not in medullary. It doesn't work in anaplastic either. Okay. So what factors do we consider at the time of thyroidectomy to determine whether we're going to proceed with radioactive iodine? So I always talk to the surgeon and find out what the surgical findings were. If the surgery was complicated, if there was residual tissue still there, or it was quite a tricky operation where the surgeon may be keen for radioactive iodine to be given to mop up any potential cells left in that surgical field because they don't want to go back in there because the risks of repeat surgery are high. We talk to the pathologist and discuss the histological findings. And basically on the basis of those two findings, we determine whether we're going to proceed to radioactive iodine. We've done a risk assessment, and then we determine if you're low, intermediate or high, and whether you should have radioactive iodine and what kind of dose to give. Now, molecular markers are an evolving area where you can test. I believe you just had a talk from Bruce Robinson about patients who are radioactive iodine resistance and how a variety of tyrosine kinase inhibitors can be used now. And the information of these molecular markers on the initial tumour will determine which tyrosine kinase to use. But at present, this isn't widely accepted, and you know, the initial use of it. And I think it's used more in the States than elsewhere in the world. It is very useful information, and I think it will more and more become part of the initial assessment. But at present, it's used at very variable. You know, some centres use it, some don't. In our centre, yeah, sure.
Sorry to interrupt. We've
No,
got
that's okay.
three further questions that have come in. The first one is, do you do RAI for poorly differentiated thyroid cancer?
Well, yeah, we would do it for poorly differentiated, but anaplastic is further away. For poorly differentiated, we would. Anaplastic, it's not going to work. But poorly differentiated, it can work.
The next one is, do you have a SUV threshold where you don't think RAI will work?
Well, SUV is if you have iodine 124 available in a PET scanner, and there's only 2 centres in Australia that have iodine 124 PET scanning available to determine dosimetry and SUV measurements. That's at Royal Brisbane Hospital and at the Austin Hospital in Melbourne. I believe they're setting it up. It's currently in use at Royal Brisbane, and I believe they're setting it up at Austin. But SUV is a figure that you can only get from a PET scanner, and we don't use iodine 124 because we don't have it available, so I can't apply an SUV in that situation. But I know it is used in centres that have that available, such as at Sloan Kettering.
And the next one, Dr. Rossleigh, is from Sandy. How do you determine the amount of RAI to use?
Okay, I'll go into that later on in my talk. I'll give you the numbers there. Okay, postoperative scanning can be considered if the findings may alter your management. And if you are going to do a postoperative scan, it's probably better to use iodine 123 because that won't result in stunning of the cells, but it's not readily available. It comes into our country, into Australia once a week from Japan, and it's very expensive. If you are going to do I-131 imaging pre-treatment, then you should try and do it up to 3 days before administering the treatment to reduce the risk of stunning, which may reduce the uptake of the treatment dose and the efficacy of the treatment. In addition, postoperative thyroglobulin reaches a nadir, you know, the lowest point, at about 3 to 4 weeks, and measurement at 6 to 12 weeks may aid in decision making. So if you're not sure whether you're going to give it or not, if it's a low risk patient with some intermediate risk features and you're determining whether you're going to give an ablative, you know, an adjuvant treatment or just get rid of normal thyroid tissue, you may rely on the postoperative thyroglobulin. And if the thyroglobulin is undetectable, that may be considered favourable, and an elevated thyroglobulin may support proceeding to radioactive iodine. So that may also be used in the decision-making process. Now, at our institution, I'm very lucky. We've got very experienced thyroid surgeons who do a lot of thyroid surgery each year. And so as a routine, if I get a patient from one of those surgeons, I don't do a pre-treatment radioactive iodine scan. I just decide on my treatment dose based on the risk assessment, which I'm going to go into in a second. But if it's from an outside surgeon and I don't know you know, how good the clearance will be, then I would do a pre-treatment scan. So in low risk disease, either I wouldn't give any radioactive iodine at all, and that's generally my stand. I figure if a patient's got low risk disease, then I don't want to give radiation unnecessarily, because I think there's only a point giving radiation if there's an indication. But in some patients, if they've got high anti-thyroglobulin antibody levels, I would give a low dose, which is a 30 millicurie or 1.1 gigabecquerel dose. And that's basically for remnant ablation, just to get rid of normal thyroid tissue. So that doesn't treat the cancer, that just gets rid of normal thyroid tissue. And in that way, the anti-thyroglobulin antibody levels should drop, and then we should be able to monitor them with thyroglobulin. It hasn't been shown that remnant ablation alone will reduce the rate of recurrence or death, but these are patients with low risk disease who have a very low rate of recurrence or death in the first place, so it's a hard thing to prove. Now, in someone with intermediate risk thyroid cancer, then you would consider giving adjuvant treatment. And in general, I think, you know, you'd give at least 75, 100 millicuries of radioactive iodine. 30 millicurie may be reserved for someone with intermediate risk disease, but with features in the lower end, and you may just do remnant ablation. So the higher administered activities are given when you are considering adjuvant treatment. So adjuvant treatment means you're trying to get rid of any microscopic cancer cells that are remaining in the body.
Dr. Rossleigh, there's some more questions that have come through. I'm not sure about this one, but it says, what is stunning?
Okay, so stunning is when you give the radioactive iodine and it shows where the cells are, that radioactive iodine's got a bit of beta ray in it, and it can then stop the subsequent treatment dose from actually working well, because the scanning dose has stunned those cells and then they won't take up the treatment. So that's why I prefer not to use pre-treatment I131 scanning, because it can alter the efficacy of the subsequent treatment.
And the next one is, in the setting of metastatic disease, that is FDG-PET avid, do you consider RAI?
You can what?
Do you consider RAI?
Yeah, if it depends what the iodine scan looks like and what or the thyroglobulin is, but I'll go into it later on in my talk about radioactive iodine resistant. So if you're no longer sensitive to radioactive iodine, basically you have to give a dose to show that you're not sensitive to it anymore, and then you would be considered for tyrosine kinase inhibitor therapy. So even if they're PET avid, I'll show you some cases at the end of this talk. We have given radioactive iodine until we're convinced they're no longer radioactive iodine sensitive.
Just one more's come through.
Sure.
Does the TG need to go down to 0 to be cancer-free after RAI?
Okay, so some patients have a thing called biochemical incomplete response, where the thyroglobulin hasn't gone down to 0. And in those patients, we tend to monitor them and look at the doubling time of the thyroglobulin. And if you look, I've got one patient, he was a young boy when he presented, and he had a total thyroid, he had papillary cancer with lymph node metastases. And he had a total thyroidectomy, the lymph nodes were cut out. He had a dose of radioactive iodine. His thyroglobulin has remained at 3 for years now. For like 8 years, his thyroglobulin hasn't done anything. We've done PET scanning, we've done neck ultrasounds, we've done iodine. There's no evidence of the disease and there's no doubling. So, you know, he's living a normal life, but his thyroglobulin is 3. So in some patients, you're going to get an incomplete biochemical response, and then you determine whether you need to do any more by following people up and seeing what their thyroglobulin does.
Dr. Rossleigh, we've got an asking of a question. Is he RAI refractory?
This patient I'm describing now?
Yeah.
No, he's not. He's had radioactive iodine. It's treated his disease. He's still got some tissue somewhere, but it's not doing anything. So I wouldn't consider him radioactive iodine refractory. If for some reason his thyroglobulin goes up in the future, if he doubles his thyroglobulin, it goes up, then I would certainly consider giving him another dose. But at present, it's not warranted because his thyroglobulin has remained quite stable. Any other questions, Susie?
Not at this point, no.
Okay. All right. So if I'm giving adjuvant treatment, I would normally give at least 75 or 100 millicuries, 3 to 4 gigabecquerels. I may give more depending on the histology, may give up to 150 or 5.5 gigabecquerels. Now, in patients with high-risk disease, administered activities between 100 and 200 millicuries, or 4 to 8 gigabecquerels may be given. But in patients over 70 in general, we avoid giving more than 150. Having said that, I'm going to show you a case where I gave more, but she was fine afterwards. It's just that in an older patient, their renal function may not be as good and the radioactive iodine may hang around in their body for longer. If you've got the facility for whole body and blood clearance, dosimetry can be used, but that's really only available in some very high volume centres, and it's not routinely used in Australia.
Just another question, Dr.
Sure.
Rossleigh. What is the doubling time for thyroglobulin that worries you about progression of disease?
Well, I mean, you just look at how I can't give you an exact number, but if the thyroglobulin, you know, it goes 3 and then 6 and then 10 and then 20, then you think, oh, I better give him another dose. So it's just a matter of looking at the trend of the thyroglobulin, and we would discuss the patient at our multidisciplinary meeting, and there'd be a group recommendation. And I'll show this later on in my talk. So, you know, if you've got a thyroglobulin over 10, that would be an indication for an empiric dose of radioactive iodine. Here we go, empiric therapy in patients who've got a negative radioactive iodine scan, but an elevated thyroglobulin. So patients with no imaging evidence of disease, but biochemical persistence or recurrence may be given an empiric dose of radioactive iodine. That is we just give a dose because the tumor marker's elevated, the thyroglobulin's elevated, and you'd give between 100 and 200. Or if you've got dosimetry available, you could use dosimetry. And in our institution, in patients like this, and I'll show you one case at the end like this, we would do a pre-treatment TSH stimulated PET scan because this would provide additional useful information. So in patients with a rising thyroglobulin, if you give an empiric dose of radioactive iodine, in about half of those patients, the thyroglobulin will drop on follow-up. But if the post-treatment scan is negative and if the thyroglobulin doesn't fall, then the patient has got radioactive iodine refractory disease, and further radioactive iodine should not be given. So empiric therapy can be considered if the thyroglobulins are over 10 with thyroxine withdrawal, or over 5 with TSH stimulation, or if the thyroglobulin or thyroglobulin antibodies, which can act as a surrogate marker, are rising. You should always have a post-treatment scan after radioactive iodine to look for disease staging, to document where the radioactive iodine treatment has gone to, and to determine which structural lesions are radioactive iodine avid. At the time of your radioactive iodine scan, if you've got a SPECT CT machine available on your gamma camera, adding the CT helps in the anatomical localization of the sites of uptake, and I'll show you some examples of that at the end of the talk. So what's the role of imaging in the follow-up of patients? So neck ultrasound examination is really the mainstay in the routine follow-up of differentiated thyroid cancer. So according to the American Thyroid Association guidelines, and really widely accepted by other international organizations, patients should be assessed at least twice a year for the first 2 years with clinical examination, thyroglobulin measurement, and neck ultrasound assessment. If there's no evidence, no features of concern, then it can be extended to once a year. We used to do a lot of radioactive iodine scanning. I think, Susie, when you had the treatment, we did a lot in follow-up, but now we don't do radioactive iodine scanning. We rely more on ultrasound and the tumor marker in the blood. But if you've got patients who you're concerned about, if they've got biochemical or structural evidence of persistent disease, then a radioactive iodine scan may be useful, and we would do it in that situation. And it would also be useful in patients with high-risk disease with biochemical or structural evidence of disease or indeterminate findings on other imaging. So in a select group of patients, we do radioactive iodine in follow-up, whereas in the past we used to do it routinely.
Dr. Rossleigh, just another question.
Sure.
Is it important that the ultrasound used for imaging needs to have high resolution?
Well, it's always good to have good equipment. But the thing with ultrasound is you not only need to have the good equipment, but you need to have people experienced in looking in the neck and following up thyroid cancer patients. So the ideal is to have good equipment and someone interested in thyroid cancer following you up. That's not always available. that always can't be guaranteed. But
and
that's the idea.
Sorry, Dr. Rossleigh.
Yeah, no, how often?
How often would you recommend neck ultrasound follow-up?
Look, as I was saying, we review patients 6 monthly for the first 2 years, and I will do a baseline neck ultrasound at 6 months. And then depending on what that shows and what the thyroglobulin is, I may repeat it in another 6 months or in a year then. It depends on other factors as well. But in general, you're reviewed 6 monthly for the first 2 years, and you may have a neck ultrasound every 6 months, or you might have it at 6 months and then a year later, depending on other factors. Okay.
Yeah.
So other,
just another one.
Another one? Okay, no problem.
Is neck ultrasound recommended every year for 5 years with a normal TG test result?
Yeah, well, in general, they say that you should have a neck ultrasound annually for the first 5 years. And if it's clear and your thyroglobulin's negative, then you can just be reviewed annually with clinical examination and thyroglobulin. That's the way I practice, and I think that's in the ATA guidelines as well. Okay, so in patients who've got an elevated thyroglobulin and you're worried about residual or persistent disease, CT or MR of the neck and chest could be performed. We also do quite a bit of FDG PET scanning if we feel the patient is at high risk and has an elevated TG, and also in the initial staging of poorly differentiated disease, because this can be a prognostic tool in the assessment of treatment response to systemic or local therapy. And I'll show you some examples of that at the end of my talk too. Now, imaging of other organs, for example, the brain or the skeleton or the abdomen, can be performed in patients who have an elevated thyroglobulin and a negative neck and chest imaging if they have symptoms referable to these organs. So we don't routinely get a CT or MR of the brain or of the whole skeleton unless patients have got symptoms in these organs.
Dr. Rossleigh, 2 further questions.
Sure.
How do you determine the ultrasound has been done correctly? Is first.
How do I do it? I send my patients to a department that I'm comfortable with, where I feel I'm going to get a good assessment. So I can't just look at the pictures and determine whether they were done properly, because ultrasound is very operator dependent. It really depends on the ultrasonographer doing the study, how they're imaging it, and the radiologist involved in the reporting of it. So I send my patients to centres where I'm confident I'm going to get a good assessment.
And the next one and final one, is it common for the thyroid cancer to metastasize to the brain?
It's very rare. It's actually very rare. And in as you said, my 41 years, I've had very few patients with that. Having said that, I'm going to show you one patient. That's how he presented. But metastases to the brain in thyroid cancer are very, very rare.
Just a further one, are there any sites of metastatic disease such as liver that you don't think respond to iodine?
Well, there are radioactive, people can become radioactive iodine refractory and not responsive to it here. And I'm just about to define what that is. So that usually means you have to give radioactive iodine to see if it's going to work or not. Hopefully it'll work. If you then have evidence that it hasn't worked, then you go on to the tyrosine kinase inhibitors. So I'll go through now on this slide what the definition is of radioactive iodine refractory disease. So in patients with known metastases identified, may be classified as radioactive iodine refractory or resistant to the radioactive iodine in the following settings in the presence of an appropriate TSH suppression and in the absence of iodine contamination following a low iodine diet. So if there's no radioactive iodine uptake at sites of known metastases, then that means that patient's radioactive iodine refractory or radioactive iodine resistant. Or if you've got a patient who has a tumour that took up radioactive iodine in the past, but it no longer takes up radioactive iodine, that is also shows that they're no longer sensitive or respond to it. In some patients, the radioactive iodine might be taken up in some lesions, but not in other lesions. And in some patients, there's evidence of disease progression despite radioactive iodine uptake. And I'll show you a case of that at the end as well. So not everyone's going to respond to radioactive iodine. The basis of thyroid cancer management is, one, you get a good surgeon to cut everything out. And you may then have radioactive iodine postoperatively if it's deemed necessary based on what the operative findings were and what the histology was. Then patients have TSH suppression. So we manage patients by keeping their TSH as low as possible. But nothing in life is 100%. In general, the prognosis from thyroid cancer is excellent, but there is going to be a small proportion of patients where all of these measures don't work. And we are now fortunate that there are some alternative disease options available to this small number of poor patients that haven't responded to these three measures.
Dr. Rossleigh, there's two further questions that have come through. One from Amelia. Was radioactive iodine used previously for treatment of MTC?
Medullary thyroid cancer? No, not that I'm aware of, no.
And the next one is papillary with Hobnow variant and RET fusion, RAI refractory?
We would give radioactive iodine for that. I have given radioactive iodine for that. But as I said, most patients will respond to it. But there may be a small number of patients that, despite giving the radioactive iodine, their disease progresses. But in general, most patients will respond to that.
And one final one, do you do iodine if you have some sites of metastatic disease that take up iodine, but other sites don't?
Well, that's what it's saying here. That is a definition of radioactive iodine refractory. So if you give radioactive iodine and you see uptake in some known lesions, but not in others, then there's no point giving any more radioactive iodine in general. So now I'm coming to the complications of radioactive iodine. And in my practice, the biggest bugbear is the salivary gland damage, which can result in a dry mouth, xerostomia. It's a dry mouth. And that's because the radioactive iodine goes to the salivary glands. It's a normal place for radioactive iodine to go to. So we use a number of measures to try and reduce that risk, but it can happen. And if you end up with a drier mouth, and you have a higher risk of gum disease and dental problems. So we try to reduce that risk as much as possible. So we advise patients to drink fluids, plenty of fluids after the radioactive iodine. and we get them to suck lemon lollies and to chew gum starting 24 hours after the treatment. And the reason we wait the 24 hours is on the basis of some research that came out of Korea, where they showed that if you start chewing the gum and sucking the lemon lollies in the first 24 hours, all that you end up doing is increasing the delivery of the radioactive iodine to the salivary glands and delivering more of a radiation dose. So we wait until 24 hours after the treatment, and then we get the patients to chew as much gum and suck as many lemon lollies as they can to wash out whatever is in the salivary glands. Now, there is a drug called amifostine, and a group in Germany showed that it can reduce, it's not 100%, but it can reduce the effect of radiation on the salivary glands. Now, this drug is no longer available in Australia. It's not recommended. In the ATA guidelines, they don't advocate for or against it, but I do offer it to my patients. But the problem is I have to apply to Canberra, to the Therapeutic Goods Administration, to administer a drug that's not been through the process in our country, and we have to import it from overseas, and a patient has to sign a waiver that they accept that this is not a tested drug. So I offer it to the patients, but some want it and some don't. The problem with amifostine are its side effects. It does cause significant nausea, and it can drop your blood pressure. So, and we don't want anyone to vomit after the radioactive iodine, because we only have one capsule per patient. Each treatment dose is ordered specifically for the patient. So we have to give some anti-vomiting drugs with the amifostine. And if the patients are nauseated, we give them more different kind of antiemetic, anti-vomiting drugs. And once that sensation has passed, then we can give the radioactive iodine. And they can drop their blood pressure after that infusion. So the amifostine is given intravenously over an hour before we give the radioactive iodine. And if they drop their blood pressure, we keep the patient horizontal and give them some liquids in through the vein.
Dr. Rossleigh,
sure.
Sorry, we have 5 more questions and 15 minutes remaining.
Okay.
I can review the questions.
Okay.
If someone is not a surgical candidate for thyroidectomy, can you do uptake scan after lenvatinib for metastatic disease?
If they haven't had their thyroid out in the first place. If you've still got a thyroid in, then all the iodine is going to the normal thyroid tissue and not the cancer cells. So, yeah. What's the next question? Yeah.
Digressing a little, may I know your thoughts on taking organics produce?
Well, I say to patients, I don't mind what you take. My cousin takes a lot of organic produce. She had lymphoma. She said she was going to treat it organically. And I said, that's fine. Take whatever organic product you like. But if you want to live longer, you need to have the chemotherapy for the lymphoma. So I don't mind what my patients take. But as long as there's no iodine in the organic product before I give the radioactive iodine. So if you can stop it before the treatment, I don't mind what you take after the treatment.
The next one, can you predict a person's chances of getting thyroid cancer?
No.
And the next one by Kat is it possible
I guess the only exception would be, at Chernobyl, if you're in a nuclear accident like at Chernobyl, that was quite predictable. All those kids got thyroid cancer. So, okay, the next question.
Is from Kat. Is it possible to have a rising thyroglobulin years after total thyroidectomy and RAI? And does that definitely mean the cancer has returned, metastasized?
Well, I don't know about metastasized, but it can come back after many years. And that's why in the guidelines, there's kind of no cutoff as to when you should stop monitoring patients, because thyroid cancer can recur years later. It's very rare, but it's possible.
If received RAA post-surgery and follow-up, I123 scan is clear, but years later reoccurrence is detected, would there be an indication to use RAA again, or would the lymph node metastases and reoccurrence be indicative that the RAA was not really effective?
Okay, sometimes you can get recurrence, and lymph node metastases need to be cut out because the radioactive iodine may not go into the lymph nodes. So that's kind of a site where you may need to have another operation. So with thyroid cancer, you cut it out or you give the radioactive iodine. And in lymph nodes, they always, if you get recurrence in lymph nodes, you need to have that cut out.
Can we hear the lecture completely before so many more questions? Can we hear the lecture completely before so many more questions? The lecture is very informative.
Oh, thank you. I don't know what to say to that. Thanks. Okay, I'll go through this because you said we've got limited time.
Yeah.
Some patients have a transient alteration in taste after the radioactive iodine. That does go away. I've had a couple of patients who complained that Australians like drinking beer, but the beer didn't taste as good, but eventually they got their taste back for beer. As far as fertility, women can have babies after radioactive iodine if they're given low to moderate doses. They may temporarily lose their periods for 4 to 10 months after the treatment, but the fertility is not affected. And it's possible that menopause may come 1 year earlier. It may also cause a reduction in the sperm count, but that again is temporary. Infertility, miscarriages, and fetal malformation is not elevated in the long term in those receiving low to moderate doses. Now, there's a very low risk of second malignancies, including leukemia, stomach, when you swallow the radioactive iodine, colorectal, because it goes out through your bowel, kidney, bladder, and salivary glands. So that's why you always need to do a risk-benefit analysis before you decide whether you're going to give radioactive iodine. Look, if you've got a cancer that shows some bad features, well, we've got to treat that cancer. And there is a low risk that you may get a second cancer from that treatment. But if you've got a cancer that's been adequately treated with surgery and doesn't have any high risk features, it's low risk disease, then I wouldn't give radioactive iodine. So it's a risk benefit analysis. We've got a cancer now, we've got to treat, and then you get on with your life. But there is a low risk of second malignancies. People can get nasolacrimal gland dysfunction due to blocked ducts after the radioactive iodine, and you may need to have your tear ducts opened up. That's a rare side effect. I just want to show you a couple of cases. So this is Phil. Phil had an operation earlier this year. He was 67. He had a total thyroidectomy for papillary cancer with vascular invasion and lymph node involvement. Because of the vascular invasion, he had a lot of lymph nodes involved. He was considered to have intermediate risk disease, and I gave him a standard 100 millicurie dose. And this is his post-treatment scan. So you can see in the neck, that's just some residual tissue in the neck. So no matter how good the surgeon is, they want to preserve your nerve to the voice box, the recurrent laryngeal nerve, your parathyroid glands. So invariably, there's a bit of thyroid tissue left behind. I don't know if it's normal thyroid tissue or cancer cells, but the radioactive iodine is going to get rid of that. Now, in Australia, we have to admit people for the treatment, and they sit in a room for 3 days. And with this sitting in the room, often they get constipated. So this is the scan he had on Monday. You see he's got a lot of radioactive iodine sitting in his bowel. The bowel doesn't need to be treated. So we gave him some Coloxyl. We often have to give an aperient to get the patients to get rid of whatever's in their bowel. And he's doing well. Now, this is Marina. Marina comes from overseas, and in her country of origin, she was 16 and she was found to have a thyroid nodule, and the biopsy was said to be benign. She then migrated to Australia. She was brought out by her brother, and at the age of 23, she had this neck lump investigated, and again, it turned out to be a papillary cancer, and she probably had it all along from the age of 16. And she had a lot of lymph nodes in her neck, and she had pulmonary metastases that had spread to her lungs. So she underwent a total thyroidectomy and central and left lateral neck dissection. So she had a lot of lymph node disease cut out. Postoperatively, I gave her a big dose, 156 millicuries, and her thyroglobulin was 15. A year later, her thyroglobulin was still elevated. I gave her another dose, and I'll show you those scans. We did a follow-up chest CT after the second treatment, and she still had these tiny sub-centimeter nodules, hadn't changed from before the baseline. So I'll just show you some of her scans. So you can see in the neck, she's got a lot of tissue in the neck, and she's got uptake in her pulmonary metastases. So a year later, you can see all the disease in the neck has gone, and there's only very faint uptake in these pulmonary metastases now. So we haven't given her any more treatment since 2015. So she's now 30 years of age. She's 1 day difference in age to my daughter, and her mum, Marina's mum, lives overseas, and I'm like her second mother. So I worry about her, but her thyroglobulin has been quite stable with suppressive TSH at 2. It hasn't gone up at all. We've discussed her case many times at the multidisciplinary meeting and have decided, look, her thyroglobulin's stable, it's not going anywhere. She's a young woman. I don't want to give her more radioactive iodine unless I really have to. We do neck ultrasounds on her. I examine her. Thyroglobulin stable. She may recur in the future. She may need radioactive iodine in the future, or she may not. Time will tell. This is another young woman who also came from overseas. And in 2011, at the age of 31, she had a total thyroidectomy and for papillary cancer. In 2017, she had a left lateral neck dissection for recurrent disease. Now, I wasn't involved in any of her treatment then, but she informs me that she'd had 4 doses of radioactive iodine. The first one was 180 millicuries, and then the next 3 that she got were 150 each, and she received them for elevated thyroglobulins and after the left lateral neck dissection. But she said after the last 3 doses, all her scans were normal. So as you can imagine, I was really not keen to give her any more radioactive iodine, but she was referred to us because her thyroglobulin was up and they wanted to know whether we should give her radioactive iodine. So we did a withdrawal scan. We did a TSH stimulated radioiodine and an FDG PET scan that people have asked me about. So this is her iodine scan. It's completely normal. She's got nothing in her neck at all. This is normal stomach and bowel and out through her bladder. There's nothing on her iodine scan. And we did a SPECT CT of the neck. And I just want to draw your attention to the right neck. There's nothing at all there on the iodine. So on the basis of the iodine scan, I didn't want to give her anything. Now this is her PET scan, and she's got an FDG avid, a PET avid lymph node in the right neck. She'd had left neck dissection in the past. So I think this is where her thyroglobulin's coming from, disease in right lateral neck lymph nodes. And I think ultimately she's going to need a lateral neck dissection. This is Otto. Someone asked me about cerebral metastases. I've only had 3 or 4 patients in 41 years. With cerebral metastases. He actually presented. He presented with his cerebral metastases, and he had a lot of lung lesions. And initially they thought he had lung cancer that had spread to the brain. But when he went to theatre and he had the metastasis cut out, and it turned out to be from the thyroid. He had a total thyroidectomy and central and lateral neck dissection, gave him a high dose of radioactive iodine, but he had no uptake in all these lung metastases. He was then put on some tyrosine kinase inhibitors. Dr. Robinson just gave that talk. And we did an iodine scan, and now this is called redifferentiation therapy. And I gave him another dose. And after that second dose, his thyroglobulin fell. So I just want to show you the pictures. After the first iodine dose, he had some uptake in the neck, but you can see all these pulmonary metastases, the cancer in the lungs, and there's no iodine uptake there. Now, after the tyrosine kinase inhibitors, he had uptake in some neck nodes and uptake in the lungs. So you can see, these pulmonary metastases taking it up, and his thyroglobulin dropped, and he actually survived for quite a few years after this second treatment. He's now had disease recurrence. He's on some tyrosine kinase inhibitors. The last case is Dora, and Dora, who's now well over 80, she's 82, 83. In November 2014, she had a poorly differentiated. Someone asked me about poorly differentiated. Hers was poorly differentiated thyroid cancer with disease in blood vessels and a lot of lymph nodes involved. She had bone metastases at presentation. We gave her a big dose of radioactive iodine. She still had pain in the metastasis in T3, so she got external beam, and that controlled her pain. A year later, I gave her more big dose of radioactive iodine. Her thyroglobulin was huge, as you can see here. And the post-treatment still showed good uptake. We did a PET scan, and her PET scan was pretty unimpressive, and I'll show you. So she's got quite iodine avid disease, but not hot on PET. So that means it's quite indolent disease. And in November 2018, her thyroglobulin was going up, so we gave her a third dose. Despite that third dose and good uptake in her bone metastases, her thyroglobulin continued to rise, and so she's now really got radioactive iodine refractory disease. We referred her to Dr. Robinson to consider TKI therapy, but really she's living a normal life. When she gets some pain in the metastases, the radiotherapy seems to control it. So she's not on the tyrosine kinase inhibitors, and she's doing fine. So that's, I'll just show you, you can see she's got very avid disease. That's her bone metastasis. You can see it's quite hot. And this is another bone metastasis, which was quite hot in T12. And she had a rib metastasis. They're all quite hot, but this is her PET scan. It's not very hot at all. So this suggests she's got indolent disease. So that's all I've got, but I can see there's a few more questions, Susie.
Yeah, there's two more, and we've got 5 minutes left. So the first one's Beverly. After RAI, for how many days do you recommend hydration and lemon lollies?
Usually just while they're in hospital, so 2 to 3 days.
And the final one, you have earlier discussed about I-123 and I-131. Can I say that I-123 is more effective in treating thyroid cancer cells? And can I know why it is not readily available?
Now, I-123 does not treat the thyroid cancer cells because it's a pure gamma emitter. It doesn't, the I-123 is only used for imaging. You can't use it for treatment, because for treatment you need beta rays, which are in the I-131. So the I-123 may show up the cancer cells better, but it doesn't treat the cancer cells. Why don't we have it in Australia? Because we don't have a cyclotron big enough to produce it. So it's all a matter of money. You know, with the health dollar, we could spend all the money that we get from taxation on health, and we still wouldn't have everything that we want. So we don't have a cyclotron in this country that produces I-123, and we have to get it in from Japan. And that's the story.
Dr. Rossleigh, there's one more, I think, before
Sure.
we wrap up, and that is from Renee. Would you mind explaining what FDG means and what is the difference between PET scan analysis and CT scans?
Okay, so FDG is FDG is fluorodeoxyglucose. FDG is the radioactive sugar, and that is a positron emitter, and it's used for PET scanning. So it's a specific agent that we use to do the PET scan, and cancer cells will take up the radioactive sugar. The cancer cells take up the sugar. So FDG is a radioactive sugar used in PET scanning. And PET scanning, like other nuclear medicine scans, like iodine scans, they're functional scans. So they tell you about the function, disease function, whereas CAT scanning is a different technology, and that's great technology for showing you structure. So you confuse the PET and the CT, you've got function and structure. Thanks, everyone.
Thank you.
Thanks.